So we conducted a phase 2 trial looking at intense androgen deprivation therapy prior to radical prostatectomy for men with high-risk prostate cancer. And as we know, prostate cancer is the most common cancer in men in the U.S. The majority of patients present with localized disease, but 15% of those patients actually have high-risk features based on either PSA, Gleason score, or stage. And the 15-year prostate cancer specific mortality for those patients can be upwards to 38%. So we're really in need of additional refinement of our treatment options for these patients. The treatment paradigm for patients with high-risk disease really has not changed over the past several decades and includes either radical prostatectomy followed by adjuvant or salvage radiation therapy with hormones or definitive upfront radiation therapy with hormonal therapy. Neoadjuvant treatment is really the standard of care for breast, rectal, bladder, and other cancers. And it's important in improving survival and long-term outcomes in these other solid tumors. It is important in downstaging local disease, which may facilitate surgical resection, and it provides an in vivo assessment of response to treatment. There have been a series of neoadjuvant trials that have been conducted over the past several decades. In the early 1990s, there was a series of trials conducted with LHRH agonists and first-generation anti-androgens. The majority of these trials were really done in low-risk patients, and they didn't really systematically evaluate response. They had limited long-term follow-up, and they were really looking at rates of positive surgical margins as opposed to pathologic response rates. With the advent of more potent androgen targeting agents such as Abiraterone, enzalutamide, Apalutamide, that really provided, and the efficacy of these agents in the metastatic space, that provided an opportunity to investigate these drugs earlier on in the disease course. And so we've conducted a series of trials now utilizing these more potent hormonal agents. These trials were done in high-risk patients as opposed to the lower-risk patients from the historic trials. We systematically evaluated pathologic responses via central review, and we have long-term follow-up from these trials that we've now been conducting for over a decade. And from our initial trials, the neoadjuvant Abiraterone trial, which enrolled about 58 patients, the neoadjuvant enzalutamide trial enrolled 40 patients, and the most recent trial that we published, the neoadjuvant Abiraterone and enzalutamide study, we demonstrated pathologic responses, meaning either a complete response or minimal residual disease that ranged on the order of upwards to 30%, in these studies. Now, understanding that these are limitations from these small phase 2 studies, but in aggregate, I think this data highlights that there's a signal that there's pathologic responses that are observed with more potent hormonal agents. We also looked at correlating pathologic responses with PSA recurrence and conducted a pooled analysis from our former, contemporary neoadjuvant studies. And really what we showed was there were no recurrences that were actually observed in patients who had a pathologic response or minimal residual disease at radical prostatectomy. And we're currently in the midst of updating this data. Some of the pathologic endpoints that we looked at, while there's constraints in the phase 2 space, really it provides an opportunity for rich correlative analyses in the context of these studies to try to understand biomarkers of treatment response and therapy resistance. And in doing so, it seems that, there are signals that certain tumors may be hardwired to respond better to hormonal therapy, particularly those that have SPOC alterations, while tumors, for example, that have TP53 alterations, TEPRIS-ERG fusions, or PTEN loss, those seem to be markers that have been associated with resistance. And so really, this is sort of the backdrop that led to us designing our current trial. And we asked the question of, does more potent neoadjuvant treatment with Abiraterone, Apalutamide, and Leuprolide result in improved pathologic responses and rates of biochemical recurrences in men with high-risk prostate cancer? So in this trial, we enrolled patients with prostatic adenocarcinoma with a Gleason score of greater than or equal to 4+3 equals 7, PSA greater than 20, or T3 disease on prostate MR. Patients were required to have lymph nodes that were less than 20 millimeters at study entry, and patients were randomized 1-to-1 to receive Abiraterone, Prednisone, Apalutamide, and Leuprolide for 6 months, followed by radical prostatectomy, or Abiraterone, Prednisone, and Lupron for 6 months, followed by radical prostatectomy. That was part 1 of the study. Part 2 of the study, which is currently ongoing, randomized patients post-prostatectomy to either continued hormonal therapy versus observation. 70% of the patients that were enrolled on the trial and underwent radical prostatectomy were actually randomized to the part 2. But for today, we'll highlight the results of the part 1 study, which is really focusing on the neoadjuvant component. The trial enrolled 120 patients, and the primary endpoint for part 1 was the rate of pathologic complete response for minimal residual disease, which was defined as less than or equal to 5 millimeters of tumor remaining in the radical prostatectomy specimen by central review. And so in total, 119 patients enrolled. There were 60 allocated to the Abiraterone, Prednisone, Apalutamide, Leuprolide arm, 59 allocated to the Abiraterone, Prednisone, Leuprolide arm. And of those allocated to the quad therapy, 55 patients underwent a radical prostatectomy. And for those allocated to Abiraterone, Prednisone, and Leuprolide, 59 patients ended up undergoing radical prostatectomy. And as I stated in the eligibility criteria, this trial really enrolled a high-risk patient population. The majority of patients had T3 disease. 94% of patients had NCCN high-risk disease, and around 42% of patients had Gleason 9-10 disease. So this was really a high-risk patient population. We did see that there were dramatic declines in PSA. They were seen early and persistent, and PSA pre-prostatectomy was 0.03 in each arm. And really what we highlight in this work is that PSA is not really a good surrogate for pathologic response, but we did see declines in PSA on treatment. And really the take-home message with regards to the pathologic response was that the PathCR minimal residual disease rate with Abiraterone, Prednisone, and Leuprolide was around 20%, with a complete pathologic response rate of 10%. And with the addition of Apalutamide, the response rate was 22%, with a PathCR rate of 13%. Positive surgical margins ranged from 7% to 12%. The nodal involvement ranged from 7 to 17% between the arms. There was great variability in percent cellularity, and that was seen in the pathologic endpoint. There was no new signal of worsening treatment, new signal with regards to adverse events. The treatment was actually safe. There was no increased peri or postoperative complications that was observed in the context of this trial. So really, in summary, was that intense neoadjuvant hormonal therapy did appear to benefit a subset of patients with high-risk prostate cancer. It appeared that the combination of Abiraterone, Apalutamide, and Leuprolide did not appear better than Abiraterone and Leuprolide, so we did not see a signal between the arms that one arm was better or worse than the other arm, but we did observe that a subset of patients did have dramatic responses. Our data support the design of the current phase 3 trial, Proteus, that is currently enrolling patients. That's asking the question about the role of Apalutamide with Lupron given perioperatively. And this trial will also look at pathologic response and also metastasis-free survival as a co-primary endpoint for this study. I mean, really what we're most excited about from the series of this work is being able to identify intermediate pathologic endpoints in prostate cancer. Prostate cancer has a very long natural history, and if we can identify intermediary endpoints to advance treatments for those with localized disease, that would be a huge advantage for our patients. This trial really integrated, imaging and tissue biomarkers, and can we use those biomarkers for consideration regarding treatment escalation or intensification or de-escalation. We're really interested and excited in defining exceptional responders. Are there a subset of patients who may not even require radical prostatectomy, and can our biomarkers, both imaging and tissue, help us identify who those individuals are? I think these are some of the provocative questions that we pose with this work, and hopefully our continued efforts will shed some light on some of these questions. And also defining the non-responders, and are there a subset of patients who are better with chemotherapy, for example, as opposed to hormone therapy, or are there a subset of patients who need post-radical prostatectomy therapy escalation, depending on their response and depending on the molecular features of their tumor. So, we're really super excited to present this work. It's really the work of many individuals. Certainly my mentor, Dr. Mary Ellen Kaplan, has been the figurehead behind this series of trials that I presented, and it's been a team effort with pathology, urology, our radiologists, and just a lot of people that have been involved in this program.